We'll now have questions from the members of the subcommittee. I should mention that everyone, again, that members of the full committee are going to participate, in the same way and have 5 minutes each. And if you if you were here and passed on the opening, you'll get an extra minute. But if you weren't here, then you don't get the extra minute, just to make the rules clear. And I'm going to start with myself. I'm trying to get two questions in here, one about the need for comprehensive reform and one about the public option. So I'll start with the comprehensive reform, but if we go too long, I may stop because I want to get to the public option too. Mr. Nees, the National Coalition on Healthcare has always envisioned the need to address health reform in a comprehensive manner, as your testimony sets out this morning. And in our discussion draft, we address issues ranging from the workforce and prevention and wellness to coverage, costs, and quality improvement. Is it possible to address this in a piecemeal fashion, or do we need the comprehensive approach to tackle this issue?
Mr. Chairman, it is absolutely essential that this be done in a comprehensive way. As we point out in our testimony and all of our published materials, it is essential that we have systemic, system-wide change in this country in our health care system. To do it piecemeal, we could end up with a system much worse. You could cover everybody, but you don't have cost containment, or you don't have it paid for in the right way, or you don't have quality. All of these principles are interdependent. They rely on one another. You have to do it all at once. You can't do it incrementally, and you can't do it piece by piece.
Okay. Let me go to Mr. Kirsten about the public option. We have a public option in the discussion draft and in a manner that assures, in my opinion, the levelest possible playing field with the multiple private insurers who will also be competing with the public option. So I have 4 questions, and I'm just going to read them and ask you to try to get through them in the next few minutes here. First, why do we need a public health insurance option? Won't the exchange function better with just the competing private insurers? Second, what do you think of the alternatives to the public options set out in our draft? People have mentioned co-ops or state-by-state options, or a public option triggered only if certain criteria are met. And then third, outside the Beltway, because I guess we don't really care much about the Beltway anymore, is the public option a partisan issue? And fourth, would a public option help or hurt small businesses? If you could try to address those in 3 minutes or less.
And try to talk not too fast. Okay. Why a public option? If we don't, we're just rearranging the deck chairs in the Titanic, and, I guess the regulation is maybe giving those chairs a shiny coat of paint. The fact is that we've had a private insurance industry that has been running our healthcare system for quite a while now. We've had wages go up, premiums go up several times much wages in some states, multiple times as much as wages. At the same time, people have poor quality care, and they're used to denial and delays all the time from health insurance companies. We need a public option to do the 2 things the President says: to lower costs, to have an actor in the system that's mandate to have the kind of lower cost operations it can have, and also to keep insurance companies honest, because their bottom line will always be hurt every time they pay for a significant claim.
What about the alternatives, the co-ops,
the alternatives
the trigger?
Are basically ways to kill the public insurance option. The trigger is basically saying we're not going to have it unless things get worse. There's an old expression, fool me once, shame on you, fool me twice, shame on me. The insurance industry basically said in 93, 94, leave it to us to fix the system. We see what we've gotten. We can't wait any longer. We've waited a long time for the insurance industry to fix the system. They failed. The co-op, interesting, a comment from Oppenheimer and Company analyst says the co-op proposal is a great gift to publicly traded insurance companies. It's doomed to fail. It was basically a political invention to try to placate Republicans who didn't want a government role in providing an option, and it has no policy benefits. We have lots of nonprofit insurers in this country that haven't done the market-changing factors we need to provide the kind of care.
Third would be outside the Beltway. Is the public option a partisan issue?
No, it's extraordinarily popular. I mean, we did the first polling question we asked was, would you prefer a public plan, just a choice of just public insurance, just private insurance, or public or private insurance? Not only do 73% of Americans say they want a choice, that including 63% of Republicans. In the case of the New York Times poll just released over the weekend, 72% of Americans say they want a choice of a language as a government administered plan like Medicare to compete with private insurance. So it's using the government word, and still 73% of Americans want it, including 49% of Republicans, which means more and many fewer than that opposed it.
What about the impact on small businesses?
And small businesses, like everyone else, need lower price coverage. And again, there's lots of things in your legislation that make a huge advantage to small business. We should talk about it. One of those is the public option, because to the extent the public option is offering good quality at a lower cost, small businesses will benefit.
Thank you. Mr. Burgess.
Thank you, Mr. Chairman. Dr. Parente, first off, you were, the buzzer or someone interrupted you, or you were about to make a point about not having a CMS director. Would you care to finish that point?
Simply to say that there should be a CMS administrator, given that there's $400 billion that has already been spent by that program. If you want to bend the cost curve down, one of the places where the costs are going out the door right now is Medicare and Medicaid. That needs active management. If even people were to put in modernization for some of the fraud things that have been put on the table, some of it actually in the bill, that would be useful. But right now, because it's essentially a caretaker administration over at CMS, none of that can occur.
Let me ask you a question, and certainly, hats off to your group for doing that exhaustive work on the Kennedy bill under such a short period of time. Are you going to do a similar scoring for the draft discussion that we have in front of us this morning?
Yes.
And when might we expect for that information to be publicly available?
I am hoping that it would be on the HSI website by tomorrow morning at 8 a.m.
Tremendous. Thank you for doing that as well. Now, when you were here last fall, I think it was the day after Lehman Brothers failed, if I recall correctly,
yes.
And the whole world changed. You talked this $4 trillion figure that you talked about for the three tiers of the public option under an FEHBP type structure. You also referenced a low end that would be essentially Medicaid for all, that would be much less expensive. And if I recall correctly, that was about $60 billion a year, or $600 billion over 10 years. Do I recall that correctly?
That is correct.
Now, assuming that reality lies somewhere in between those two, well, let me just ask you this. Have you looked at, under the proposal before us today, Medicaid is offered, a full federal component of Medicaid is offered for everyone at 133% of poverty and below, not just the existing populations, but for all populations. Do you have an idea what the cost for that is?
And not as specifically. Actually, the public option plans with the subsidies that are proposed, at least in the Kennedy bill, addresses a fair bit of the population. A round guess on that cost would probably be somewhere in the vicinity of about no more than about 30 or 40 billion per year.
Very well. Let me ask you a question. And we hear the president all the time. In fact, he said it at the White House last March, that the only thing that was not acceptable is the status quo. And if you like what you have, you can keep it. Well, it's kind of tough to reconcile those two positions. Do you think under the bill that's under consideration today, the draft bill, the Tri-Caucus bill that's out there, do you think it's reasonable to assume that if you like what you have, you can keep it under the parameters of the bill that are before us today?
I think it really determines how the public plan is ultimately deployed. I mean, as you all know, it is a very long road from whatever this legislation is to enactment, which could be 3 to 4 years from now. The concern really is crowd out. It's hard to say what the public plan model would look like in terms of logistical operational terms. If it operates like TRICARE, that could be a crowd-out potential. If it operates like FEHBP, that would definitely be a crowd-out potential because it's more generous than the standard market today.
Mr. Kirsch, let me ask you a question. In yesterday's Politico, you have an opinion piece, and you talk about the three things that are likely to make this legislation happen. And the third thing, the organization where it counts most outside the Beltway. Now, I don't know how far outside the Beltway you've gotten. In North Texas, I will tell you that 68% of the people in my district, and it's not a wealthy district. It's a working district, and a rural district, and inner city district, as well as a suburban district. But 65 to 68% of the people in my district are satisfied or very satisfied with the insurance coverage that they have today. In spite of the fact that so many people are demanding change, that seems like a pretty high number that is accepting of where they are right now.
Well, you know, it always depends on all these things and how the questions are asked. Basically, if we look at the views nationally, according to the New York Times, 85% of people believe that the health insurance system needs fundamental change or needs to be completely rebuilt. 86% believes it's a somewhat, 61% think a serious threat to the economy. What people are dealing with is they may be happy with their insurance at the moment, but what they're totally terrified of is what happens if they lose their job, and so they want a system.
Correct. And let me just interrupt you here, because I think we can address those problems and correct those problems without turning the entire system on its head. Now, the last New York Times CBS poll, that I guess is the one you're referring to, just a curious figure down toward the end of it, of the people polled, 48% voted for President Obama, 25% voted for Senator McCain, and 19% didn't vote. That's a curious sampling, and I wonder if that may not have skewed the results that were reported so widely on the Sunday shows yesterday. Thank you, Mr. Chairman. You've been generous. I'll yield back my time.
Thank you. The gentlewoman from Colorado, Ms. DeGette.
Thanks. Thank you very much, Mr. Chairman. Dr. Parenti, I read your testimony, and I wanted to talk with you a little bit about some of your analysis around the public plan and cost savings and so on. I certainly agree with you that we need to try to get cost savings in Medicare and in other programs. But what we've seen, for example, in Massachusetts, since they've put together their connector system without a public plan, the good news is they got almost everybody enrolled in health care. The bad news is they got absolutely no cost savings, and their costs are going up as much as everybody. So I'm just wondering if you can tell me, and I apologize I didn't read your piece in Politico, but I wonder if you can tell me, do you think all potential public plans are a poor idea, or just ones that would cause this crowd out?
I don't think all public plans are a bad idea. I think but understand as I understand as an economist what you're trying to do.
Or at least what you've done is you've analyzed the Senate bill.
Right.
And I understand that was the bill that was out there. But we, as you know, we're a little sensitive over here about having our own bill and having it be a work in progress. So you can give your opinion on the Senate bill, recognizing that's not our bill.
I understand, and there are similarities. So there will be a lot of the structure is very similar. Like I said, I applaud some of the things that are put in for Medicare that are related to cost savings and such. A public plan is designed to inject competition into the system. What concerns me is that there already is quite a lot of competition in the private insurance market space. A few things, a few issues, just one clarifying comment. If you look at what Massachusetts did very well, it simplified the benefits so that most people can get a sense of what was available.
Right.
But if you look at what actually did the deed to get everybody covered, it was mostly through high-deductible health insurance plans.
Well, I'm sorry. I have a limited amount of time, and we have two other witnesses. But there was a study that was just released by Healthcare for America that found that 94% of the communities in the country do not have a competitive health insurance market. For example, in Pueblo, Colorado, they have one provider, WellPoint, that has 76% of the market share. And so, in fact, we don't have robust competition in 94% of the country. So I'm wondering, don't you think that a public plan might be able to help with competition in communities like that?
Not if it doesn't have active price competition. So my concern is, what if
well, let's say it does have active price competition. Then your objection is that everybody leaves the private plans because it's cheaper. But isn't that a noble goal?
To have everybody leave the private plans?
No, that people be able to buy cheaper health insurance.
Yes, that is a noble
Okay.
goal. But if you're going to regulate the public plan to basically go into price competition with the private insurance industry, you have to ask your question, how are you going to be able to price fix those public plans to be able to do that?
Oh, just so you know, at least from my view, I don't think that we should price fix the public plan and give them an artificially low price. I think most of us on this committee would think if we have a public plan, they should be able to compete with the private insurance companies. Mr. Kirsch, I'm wondering if you can comment on that study by Healthcare for America and why that necessitates the need for a public plan.
Right. Yes, Congresswoman, as you said, 94% of the markers, this is actually AMA data that we use in our study, are highly concentrated by Department of Justice standards, which means people don't really have choices. And in state after state, like in Pueblo, Colorado, and municipalities and regions around the country, it's also the question of the right kind of competition. It's having competition. It's also having competition for an insurance company that cares about people's health care more than a healthy bottom line. So it's both factors we're looking at.
Yeah, and it would seem to me, for all the panelists, Mr. Nees and everybody, that one way that we could improve our healthcare system is to get the competition, but also to try to get cost savings through Medicare. And I don't think those things are mutually exclusive. Do you, Mr. Nees?
Absolutely not, and I think we can applaud the work of some of the states like Massachusetts or Tennessee. However, they were not systemic, system-wide reform that addressed cost containment, that addressed simplified administration and other issues. You have to do it as a comprehensive package. This could be done, and I think the committee's done a good job, a good start on the public plan, trying to make sure that it will be on an equal playing field, not given an advantage, be fair and competitive.
And I won't vote for a private plan that has an unfair advantage, or a public plan that has an unfair advantage over the private plans. But I do think we need to find some place for competition to keep everybody trying to find their best price points. Thank you very much, Mr. Chairman.
Thank you. Gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, thank you. I want to address my first question to you, Mr. Kirsch. You made a statement in responding to one of my colleagues. I think the question of why the public option plan, and you said, well, the insurance company, the health insurance companies are so egregious in what they've failed to do. I think you said, fool me once, shame on me, fool me twice, or just the opposite, fool me once, shame on you, fool me twice, shame on me. Why do you feel that, based on that we should give as I think this will do, this bill, the death penalty essentially to the private market? Why not give them 30 years in prison rather than the death penalty? Why is it you want to come down so hard? Why not let an exchange function, at least for a period of time, to see how that competition works to bring down prices, as it has indeed done by the prescription drug plans in Part D of Medicare?
Okay. So let me just say that single payer would be the death sentence. This option is in effect saying you get a chance, but you don't get to have the field by yourself. I want to address this.
But let me interrupt you just for a second. You understand? I feel like that a public option is a step, a giant step toward a single payer.
So that's what I was going to address, if I could. And this level playing field thing drives me crazy. Private insurance companies have 158 to 170 million customers. They have provider networks in place. They have years of brand loyalty. They have contracts with businesses. They have a well-established place in American society. They are going to continue, as they've done in Medicare, to try to do everything possible to cherry pick and avoid people who have high health care risks, even in a regulatory scheme. In terms of a level playing field, the public health insurance option is going to start at an enormous disadvantage because it doesn't have all those things in place. And when the private insurance companies whine that they can't compete with the government, I have to begin to wonder, do they really believe the polls that say that 93% of Americans don't trust them, and that's why they can't compete?
Well, let me ask you this question. You say on page 2 of your testimony, and I quote, "The good news is that we can fix what is wrong with the system with a uniquely American solution,
Right.
a uniquely American solution similar to what we did with AIG, similar uniquely American solution similar to what we did with General Motors. What is uniquely American about interfering with the free market system in this country?
Well, first of all, we're not talking about bailing out the insurance industry like we bailed out General Motors and AIG. We're talking about giving the insurance industry some competition. And what's uniquely American about this is saying we're not going to have a system that's just private. We're not going to have a system that's just public. We're going to build on what works in America. What works in some ways is private insurance. It's got problems. Which works for our parents and grandparents is Medicare. We're going to use two systems we're familiar with and combine them, and that's the uniquely American part of the solution.
Let me switch to Mr. Parente. Mr. Parente is an economist. I'd like to get your opinion on what impact will the employer responsibility policies in this draft have on employers' ability to create jobs and put more people back to work. I want you to answer that, and I also want to know if you have seen anything in this draft legislation in regard to the reserve funds that the public plan would have to come up with, and where would they get that money to be on a level playing field with the private health insurance plans that also would be competing in the exchange?
The employer question, first of all, it really depends upon the size of the employer. Depends. There is as I have to look at this more carefully. Will be before 8 a.m. tomorrow morning, but there is the provision that there has to be some pay or play option that's in this. That will always impact employers in a way depending upon the size of those particular employers that are in place. And your second question?
Well, let me switch it over to Mr. Nees on the second question. Mr. Nees, do you see anything in this draft that calls for the public plan providing a reserve fund before they can do business, just like any other health insurance company doing business in any state in this country would have to have a certain amount of money available before they could start offering a product so that they could cover these claims that occur. They have to have that reserve. Where would it come from in the federal government plan, and how much money are we talking about?
Mr. Gingrich, I must confess not to knowing every single phrase or sentence in the bill. My recollection from going over the materials over the weekend was that the committee's plan to have this public insurance option compete on an equal level, be competitive, and as I understand it, also that there would be an initial investment with respect to the reserve at the beginning, and then the public insurance option would be self-sufficient after the second or third year. I defer to counsel and others up there and the members, but I think that's my recollection.
Mr. Nees, thank you. Mr. Chairman, thank you for your indulgence. I assumed that money would come from the general fund and from the John Q. taxpayer. Thank you, and I yield back.
Vice Chair, Ms. Capps.
Thank you, Mr. Chairman, and thank you for your testimony to each of you. Mr. Kirsch, I have your organization, Healthcare for America Now, has good representation in my district, so I'll be addressing my conversation with you because it comes right from some of the people who've been talking with me. But I did want to mention in this discussion of competition, which I'm happy we can get into, agriculture is the basis of my congressional district in California, and large parts of it are rural, therefore. And in those areas, there's only one private option. I don't call that competition. Maybe that's why there's such enthusiasm among many of my constituents for change, because they see a monopoly in healthcare delivery. If you make too much money to afford so that you can't be on Medicaid, then you have to buy this plan that they keep raising, and they do. Plus, we have a provider issue because it's a locality problem with our low reimbursement rate. So that combination is really, in so much of America, we don't bring those points together. It's a part of our reform legislation as well. So I'm pleased that we have this opportunity to really get into what competition means, and but I want to get to that in a minute. But would you just expand maybe for a minute or so on why we cannot wait any longer? There are a lot of people here in Washington, D.C., and some who are overwhelmed with our financial burdens and our economic situation, plus our debt. they are saying, why would you want to bring this up now to our president? And some of us maybe are wondering too, because our agenda is really full. Now, as I said in my opening, as a public health nurse, this is why I came to Congress, in large part because we have a system that isn't working, that is already so costly. I mean, we're talking about the huge cost of health care. We're already paying more than any other country in the world for health care. So why must we seize on this very crowded moment in our agenda to do this?
Well, I think you've answered the question yourself. I mean, you know, the fundamental point that to fix the economy in the long run we have to fix health care is just true. It's the point that the President's made, that Peter Orszag's made. Our failure to do that, our failure to have a system which provides good coverage to everyone and systemic ways of controlling cost is why we continue to have a system where healthcare inflation is larger than greater inflation, why we continue to outpace the rest of the world in how much we spend and yet get poor results. What's true about the rest of the world is they understand that healthcare is not a private good, it's a public good, and there's two things you do with a public good. You regulate it or you provide it directly.
Could I interrupt you? Do you think that feeling is shared in this country, that that's what it ought to be?
Absolutely. And again, the New York Times poll, great data from this about the public's feeling, I'll pull it out, but that the government can do a better job of controlling healthcare costs than private insurance. What the public actually understands is really interesting in this. They understand that nobody other than the government is strong enough to stand up to private insurance and the rule they have in their life, the kind of thing your constituents see all the time. Mm-hmm. They want a strong government role for regulating the private insurance industry and providing a choice, so the only choice is in private insurance. And, you know, if you look at why so many of larger employers now are saying they want reform, it's because they understand the current system's unattainable and small business is unsustainable.
Let me ask you to use, and I wish I had time to ask all three of you, I think there's a huge lack of understanding, and I hope that these hearings and our president's press conference today and all the other things are going to really help explain to the American people what a public option is, that it is a level playing field, that the public option isn't a government subsidized program any more than any of the other options will be. If we have health reform, we're going to give an opportunity for everyone to be participating, and most people, so many people, up to 400% of poverty, are going to need help.
Right, and I think what I'm finding as I talk to constituents, and you may find the same thing, is there's a huge confusion between the exchange and the public insurance option. And people, this is a new concept for people. So people ask me questions, like we're on a phone yesterday with, and they said, well, will the public option cover the following things? And I said, this is the wrong question. Yep. We're going to have and what your bill does, which is great, is it says that every plan in the exchange will have to meet these benefits. And actually, after 5 years, every employer will have to meet these benefits. So we're establishing a standard across the country. And so much of what your legislation does, which is important in terms of a level playing field, is it says we're going to create a basic standard of health care in the employer system, which is one reason that we won't have the kind of crowd out, as well as in the exchange, and the public option will be one more option in that. But that gives everybody the question of, again, will I be guaranteed good, affordable health coverage? Well, you'll know it'll be good if it meets those standards.
Mm-hmm. And I think you're absolutely right that what the public is asking for is certainty. The great fear that people have with the health plan that they may even like is that there's no guarantee that next year the premiums will go up. We did this Managed Care Modernization Act, and seniors welcomed the opportunity for a chance at lower costs, but then they found out that at any moment those companies, the insurance companies, have had nobody overseeing the way they were able to manipulate the markets. I'll yield back for now, but thank you very much, all of you, for helping us have this conversation.
Thank you. Gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman, and I want to thank all of you for being here. And I have a list of questions that I would love to go through with you all. Mr. Neese, I think I'll start with you. You know, you make a pretty bold statement on page 1 of your testimony. The economic crisis facing us cannot, which you underline, be addressed successfully without the simultaneous adoption of a comprehensive, sustainable overhaul of Americans' health care. Do you have specific research that you are citing in that, and would you like to submit that for the record?
Yes, I do,
Great.
Congresswoman.
I'd love to have
I would love to depend on the chairman of the Federal Reserve.
Okay, and let me ask you also.
Can I finish that question?
Do you have any program that was a public-private option competition that you can point to that has been successful or successfully implemented?
I think there are many examples of where there has been a public-private.
Can you cite one for me for the record?
I would certainly say that the Medicare and Medicaid and veterans, all the so-called public programs
Can you
have
look at
much
the
interaction
states
with the
and give us
privates.
one? Because we know in Tennessee and Massachusetts, they've both been shown as being examples that do not work. And, you know, there was a question in our question period, someone mentioned price fixing with the public plan. What we found in Tennessee is that you cap what is going to be paid through that public plan, and everything gets cost shifted over to the private plans, and then you limit your access, and your private insurance becomes unaffordable. In rural areas like mine, lose out. So it just really, it doesn't have a great track record, so I appreciate your willingness. Second question for you. Do you think this can only be addressed by the federal government? Can the states not help address this? Can the private sector not address this?
The states have to be part of this. The private sector have to be part of this. But we also need a national plan that is systemic and system-wide.
And you think everybody has to be in the plan?
Absolutely.
Okay, then do you agree with the premise over in the Senate where they're wanting to exempt the unions, and the union workers would not have to pay? Let's see, those that are covered under collective bargaining agreements would not be subjected to the tax. The taxes on the health care benefits. Mr. Kirsch, I see you weighing in on that. Do you want to speak on that one?
Sure. I mean, first of all, what you're talking about a question of whether or not we should be taxing people who have good health care benefits. And I think that's the wrong direction.
So tax everybody but not the union?
No. We don't think you should tax anybody's
Okay, do
health care
you,
benefits.
Mr. Neese, think the unions ought to be exempted, or should union workers have to pay on this also?
I don't think there's any provision in the Senate that's trying to treat union members differently than any member of society. May I answer a couple of your questions just for 20 seconds or so? I do want to go back to the private-public blending, the partnership. But most importantly, you just can't, as in Tennessee or Massachusetts, address coverage for all or one of these principles. You have to look at the cost. You have to look at the financing and the administration. $2.5 trillion a year in health care spending. Approximately $1 trillion of that, according to dozens of studies, is waste and inefficiency.
Let me interrupt you
the
right
money
there,
is
reclaiming
there
my
in the
time.
system.
I appreciate that, and I'm so limited on time, and I've got so many things. But Mr. Kirsch has just said that he is opposed to a single-payer system. And then your group sponsored a rally last year, and here is a comment that was made by a member of Congress said, I know many people here today are single-payer advocates, and so am I. Those of us that are pushing for a public insurance option don't disagree with the goal. It's not a principled fight. This is a fight about strategy, about getting there, and I believe we will. So, you know, we have to look at this. If we have those that say, I'm not in favor of a single-payer system, we really don't want to go there, and then others that say, well, this is a step along that way, as other members in their questioning have asked you today, I think that causes us tremendous concern. And Mr. Kirsch, I think it's fair to say that maybe you don't like the insurance companies, but nevertheless, you're wanting to get to good, affordable coverage for all. That is a goal that I have. Going through what we have done, access to affordable health care for all of my constituents, I think is an imperative. And everyone should be able to have access to that. Now, are you completely opposed to a private sector solution? Are you open to that? Or do you feel like it has to be done through government control?
Well, let me just quickly, if you're saying we're going to continue to have this solved through the private market that got us into this mess, yes, I'm opposed to that.
Okay.
15 seconds, Congresswoman. We did not have a rally last year. No one said anything like that in one of our rallies.
Okay.
I think your facts are incorrect.
Okay, I appreciate the clarification. Mr. Chairman, I will yield back, and I have some questions I didn't get to that I would love to submit for the record.
Every member can submit questions for the record. I'll mention at the end, but I can mention now. Within 10 days, we usually ask members to submit the written questions, and then we ask you to get back. Gentleman from Georgia, Mr. Barrow.
I thank the chair. We've heard a lot about how beneficiaries are going to benefit under various proposals in the Tri-County Committee draft. I want to hear a little bit more about how providers are going to benefit. Where I come from, people are mighty concerned about being able to keep their choice of doctor and their choice of hospital, but it'd probably be more accurate where I come from to talk about getting that choice back, because a lot of folks don't have a choice in the current system as to where they can go to get the treatment. And you talk to doctors, and they got this problem writ large. The consolidation of business in the health insurance sector has allowed fewer and fewer insurers to exert and abuse what is essentially a monopoly power to decide what folks are going to get reimbursed. So when I hear folks talking about how participating in a public plan is going to get you at least what you get with Medicare plus 5 or something on that order, you're talking about a system that's already so badly broke where they were ignoring what's going on in the private sector, where the private insurers say, if you're not in our network, you don't get to treat anybody because we're the only insurer in town. So what I want to know is how are the rights of doctors and hospitals going to be strengthened here? I read a lot in the summaries about how the interests are going to be served pie in the sky wise, down the road. We're going to grow the universe of providers. We're going to provide incentives for getting more folks into the game. All that stuff sounds good, but what about the rights? What can folks expect as a matter of law if this draft were to be enacted in terms of what doctors get to participate in what plans, how insurers can discriminate against doctors of good standing in their community? How is this going to change in terms of how the world looks to doctors? Who can go first on that? Mr. Kirsch, we want to take a stab at that?
Well, I think the first thing to note is that while there are some access problems in Medicare, 97% of doctors accept Medicare. And, seniors find that they get covered with a large variety of doctors in their community through Medicare, and you don't have the kind of network problems you have in private insurance where you have restricted networks, and, you may change insurance plans and you lose your choice of doctor.
I grant you the benefits package is good, or at least it's standardized. Folks have a pretty good idea what to expect in terms of what is covered.
Right.
Doctors don't like, though, the way we have abused the system with the constant sustainable growth rate issues have sort of abused that system so much it is no longer, the gold standard in terms of what doctors look for and what they expect to get. They need to be reimbursed for the reasonable cost of what they're doing.
Right, and I know that, one of the things about the SGR fix will hopefully mean that we're in a long-term path to make that more comfortable for physicians. At the same time, from a point of view of physicians participating, they participate in Medicare, and one of the things about a public option, having a stability, and we would expect physicians participating the same way they do in Medicare, particularly in your legislation paying 5% more than Medicare. You would then solve a lot of this problem of choice and stability for individuals, and then doctors would have a system that they can enter in at an enhanced rate through Medicare, particularly with the SGR fix.
So basically what you're saying is if the doctors are being pushed around by the one or two dwindling providers, payers in the market, they have a place to go.
Absolutely.
They don't have right now. It's guaranteed to be open to them.
Yep.
Okay. How about hospitals? How are hospitals going to come out of this, especially rural hospitals? How are their interests going to be strengthened or served by the draft?
A huge burden for hospitals is uncompensated care. It's an enormous, enormous burden. And hospitals are always faced with, what do you do when someone comes to the emergency room who needs medical care and isn't covered? Let's provide coverage for those folks, and that's a revenue source for the hospitals, as opposing to have to not have the revenues, hurt their bottom lines, cost shift to other payers. So, the estimates are that actually insurance policies, average family insurance policy includes $1,100 for uncompensated care. Most of that's in hospital settings, and it's one way that over time, as we get everybody in the system, we can reduce other premiums and also have a revenue source for hospitals they don't have now.
Mr. Nees, you want to chime in?
I just wanted to add regarding the doctors, and this is a very important point. I said in my testimony that we have 78 organizations that stand for 150 million Americans. One of the best things is that we have about 10 medical societies in the National Coalition on Healthcare. That was not the case in 1993 and 1994. And I know sitting down with the doctors and the nurses and others, with Henry Simmons and others on the staff, I said, why are you doing it this time? And they said, this time is different. We see an attempt to have comprehensive system-wide systemic reform. We don't mind making some sacrifice, as long as it's a shared sacrifice, a shared responsibility. We can give up something if everyone is going to be giving up something. They want predictability. They want to make sure they're getting reimbursed, but they want a system that works, that's sustainable. And I think sustainability might be the most important word that I'm going to state today before this committee. But I think that's why you're getting so much participation from all the stakeholders. This is such a different environment than 15 years ago, and I think that's the reason why.
Well, we're addressing the interests and the rights of the existing universe of healthcare providers. Let's back to the subject I passed over for a second, and that's the long-term problem of supply and demand. The fact we don't have enough primary healthcare providers, for example.
That's a big
Do you
issue.
think the incentives and the proposals that are in this bill are adequate enough, or robust enough, or muscular enough in order to be able to provide us the growth in the sector of the healthcare community that's being underserved right now not by area, but by area of practice?
We have been meeting with the medical societies, and one of our newest members, the American Association of Medical Colleges and Teaching Hospitals, and they've been pointing out to us this extraordinary workforce issue. And as you know all too well, primary doctors now only count for about a third of all the doctors in the country, sort of the reverse of what it was just 20, 25 years ago. We need more nurses, we need more doctors, we need more training, we need more money. We've got to invest in our providers, in our doctors, in our nurses.
And there are several measures in this legislation that do that. There's increases the National Health Service Corps.
My question was, are they adequate enough? You think they're strong enough to actually make a difference, to bend the curve in the areas that are being served by the
There are
healthcare?
significant investments in doing this, and which is really neat, in a whole variety of measures that the bill includes.
Right. Thank you, Mr. Chairman.
Thank you. Ms. Christensen.
Thank you, Mr. Chairman. Let me begin with Mr. Neese, and I thank all of you for being here this morning. Mr. Neese, I agree that with your statement and your testimony that this is not the time for halfway measures. But I also take the position that coverage alone doesn't, reform the system. None of the principles in the National Coalition address the huge gaps that exist in health, the health of people of color in rural areas or the poor. Where and how does the elimination of these disparities that drain the system and our communities fit in your agenda, or is it included inherently in those 5 principles?
You raise such an important issue. I was just meeting last week with many of the groups who are working on the disparity issues. The question has been asked about how urgent this issue of enacting this bill is and what's the crisis. It's an extraordinary crisis. We cannot afford to wait. And I'm addressing your issues. It's not just the federal government's fiscal crisis and economic crisis or the state and local governments, but it's the people who are being affected. 400,000 Americans die every year because of preventable medical errors and affections that they get in the hospitals just by mistakes. Millions more are harmed. Those who are uninsured or those who are underinsured, many disproportionately minority people without wealth are the most affected by this. But it affects all of society. It affects our productivity. It affects the bottom line of businesses and the state and local governments. This is a crisis of enormous proportions that cannot wait. The costs of inaction are
I'm not suggesting that we should wait. I'm suggesting that all of it ought to be included.
That is our position. That is why we say systemic, system-wide, which would address the issues that you're raising, which are very important. And without systemic, system-wide reform, you can't get to that. And we have to make special efforts to make sure every American, including those who do not now have access or do not now have the affordability issue or the quality issues addressed, get those issues addressed.
Thank you. Mr. Kirsch, I know that eliminating disparities is part of your, one of your principles. But to be able to answer the question, as you say, at the end of the day, will I have a guarantee of good coverage I can afford? To be able to answer that affirmatively, we have to fund this bill without a complete offset. Should we cut back on being able to answer that question fully just to meet the $1 trillion limit, or do you see us maybe budgeting for prevention, knowing that it will save money down in the long run?
Let me say that there are by our count, there are 8 specific measures to deal with inequities in health care for communities and people of color in your draft legislation. So that's really encouraging, and we're glad to see that. But to this question of should an artificial $1 trillion figure be used for this? Absolutely not. I understand that the Bush tax cut was $1.9 trillion over 10 years, and $1.3 trillion of that was for the 20% of people in the upper income brackets. Right. You made the decision, I think the right decision, to spend about $800 billion just for 2 years in the economic. We're going to be spending around $42 trillion in health care the next 10 years. That's assume a 5% inflation rate for health care, which is actually probably an optimistic rate. So if we're talking about at a $42 trillion, adding $1 trillion or $2 trillion, it's really important to realize that if we believe what we do believe, which is we have to create the kind of systemic reforms that in the long run can lower costs, we need to make the investment to realize these goals. And these figures that sound so large, and we're talking about 10 years and the size of the healthcare system, are really not that large. So this should be driven on doing it right and coming with the resources to do it.
Thank you. Thank you. Dr. Parente, much of the savings and reduction in health care costs, although they may be realized outside of the 10-year window, will come from community public health measures and broader policies implemented across all agencies, as well as from more efficient system and the elimination of fraud and abuse. Did you have any models that took into account community public health measures that would be implemented or addressing the social determinants of health, and did that affect the cost?
The models just aren't precise enough to do that. I mean, I personally recognize those are very good things. I actually brought along a book from 1932 that states that all the same objectives that we want to achieve here today with this bill pretty much were there. This is a long-standing goal of what we're trying to do. This is from the Committee of the Cost of Medical Care from the University of Chicago. But they can't be accounted for. And actually, a lot of things cannot be accounted for. Health IT savings cannot be accounted for easily. Prevention can't be accounted for quite easily as well. And things that 1 percentage point difference in terms of the cost increases in healthcare vastly change what these projections will look like as well.
Gentlewoman, thank you. Gentlewoman from Illinois, Ms. Schakowsky.
I want to talk about costs for a minute, because the cost numbers, and let me ask you, Mr. Neese, Dr. Parente's study looks at the funding for the federal government as if that's the only factor that we ought to consider. And I don't know, the $4 trillion or whatever, I have some disagreements over or at least my staff suggests that, having looked at that, some problems with the methodology. But that's not the central question. When do we consider total costs spent by Americans, businesses, individuals, out of pocket, premiums, co-payments, all those things? When we talk about costs, don't we have to think about the aggregate and not just the federal spending? Can you answer that, Mr. Neese?
Absolutely. Some people were upset last week by CBO, by Congressional Budget Office. And I'm not saying I agree with how they scored everything, but we're going to look back and thank the Congressional Budget Office, because they've put on the table the cost issue. And I think for this to be sustainable, we have to, as the President has said, make this budget neutral. But you asked the right question. It's not just an issue of pay-fors or the issue of the federal government. It's looking at the entire system. The best phrase I've heard so far in the last 6 months, again out of the President, is shared responsibility, shared sacrifice. Let's take the pharmaceuticals. Let's take the insurance industry. They are obviously very happy about where this is going in terms of 10, 20, 30, 40 million new customers. They are going to the table, they are participating, and I applaud them. And I know they want predictability. I know they're scared, like we all are, by the economic conditions. But they have to come to the table and give up something too. There's a lot of money that has to be saved by the pharmaceuticals, by the providers, by all of us, by the insurance companies. I said before about that $2.5 trillion. The money is in the system. We just have to spend it well. We have to look at the cost containment.
Let me see if anyone else wants to comment. Dr. Perrone.
Well, the cost issue is, I think, the dominant concern that you really need to address here. Because of the situation we were in, actually the day that I testified last.
See, I don't even agree with that. I mean, I don't even agree with that. I mean, I think that the polling showed, too, that the American people, a majority, said they'd even be willing to pay somewhat more to have universal health care. So let
me put it back to you as a question.
Yeah,
Are the American people willing to take hyperinflation that could come if this thing basically capsizes treasuries? Because if that happens, it will come because of this bill.
Mr. Kirsch?
Well, I'd say what Mr. Orszag says, which is that the current biggest threat to the federal treasury right now is the current healthcare system. And if we don't get that, our hands on that, we're really in a huge economic problem in the long run.
And the only way you can bring those costs down is a statist solution that would control costs, which, let's be honest, that is what you are advocating, a statist solution. I'm sorry I was out of order.
We're actually advocating a system that has system-wide cost containment in a way that focuses on better delivery. And, there's been a lot of discussion of this analysis, this trip from Dr. Gawande to McAllen, Texas, and looking at the perverse incentives there that lead to such high Medicare spending versus the kind of right systems that you have in a place like Mayo or others. So we got to focus on good delivery, on prevention, all those things. And what I do think is important about your first question is that we have to look at this as a whole system. For instance, if we don't provide coverage for someone in a benefit package, it doesn't mean like their health need disappears.
Right.
If you don't, for instance, I think you're generally have a good benefit package. I'd criticize one thing. You've left out dental. Now, you get that as part of your basic package in Congress. And by doing that, pardon me?
Very poorly.
Very poorly, but none in this. And it means that, how many members of the committee may have been to a periodontist and wondered what would happen if you couldn't have it. So understanding, leaving it out may save the federal government money, but it shifts tremendous cost into that family. It makes their health more expensive, makes them harder to be in the workforce. It's a whole system we got to look at.
I wanted to just make a comment. I may have time for that. This issue of competition, I think, is also bogus because right now the insurance industry and Major League Baseball are the only businesses exempt from antitrust laws, from McCarran-Ferguson. And so 94% of markets are non-competitive right now. So this argument that somehow, we ought to leave it to the private sector and competition is just absolutely false. The insurance industry has tried all its time to avoid competition, and it seems to me that the injection of a private health insurance option, and frankly, I cannot think of a public interest reason why that is not an advantageous thing to do, to have a choice of, would actually inject competition. And I yield back.
Thank you. The gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and for our first full hearing on the draft, and I appreciate our first panel, the witnesses, for being here. I have a district in Houston, Texas, and Texas has the highest percentage of uninsured in the country and also the highest number of uninsured. And I'll give you an example of why we need, I think, a public plan to compete. If the private sector could have dealt with the 45 million estimated number of people, they would have already done it because they would be making money on them. I have a huge refineries in my district in chemical facilities. About 3 years ago, the CEO of Shell, Western Hemisphere, has sat in our office and said he was transferring some production jobs from their chemical facility in our district in Deer Park, Texas, to the Netherlands. 2 reasons. The natural gas at that time from the North Sea was cheaper, and natural gas is a feedstock for chemical production, but the cost per health care in the Netherlands was cheaper than the cost in Deer Park, Texas. Now, it's a union-organized plant, and so, but that was the business decision they made. And for a number of years, sitting on this committee, I've been wanting to hear from the business community is saying, look, this is a cost issue that we have. We can't compete in Deer Park, Texas, or in parts of because of our high cost of health care in our nation. So I know there are a lot of businesses who are part of the coalitions, various coalitions on this, and I wish if you could just address that. And I know it came up in the last questioning. We have polls all over the board, but I think the one that I saw over the weekend and talked about, 70% of the American people want some type of government run insurance. Now, a public plan is not government-run insurance by any means, but a public plan with that'll give the insurer, hopefully not last resort, because otherwise it'll be so costly, but an insurance product that people can have go to have a medical home instead of short of emergency rooms. And I appreciate I'll start with you, Dr. Parente.
Yeah. I appreciate the concern about jobs. I mean, there's been research that shows that it's ambiguous just how much job loss is associated with essentially the provision of health insurance, or that cost that's associated there. That said, let me tell you what I think could work. If it starts with understanding what is insurance. Insurance technically is a provision of a policy there for fairly high cost with low probability event. That is not health insurance, nor is it health care. We throw those terms around quite a bit. If we were to offer insurance for all and call it really health insurance, that is a catastrophic plan, probably with a $5,000 or $6,000 or $7,000 deductible. And to answer the previous question about what we could do better with $2.5 trillion a year, if you distributed that with an individual mandate to the entire country, you'd have money left over. But that's not what we do. And because of that, we have over a period of time basically thrown in prevention, other services. If you think about what the medical home originated from, it originated from the HMO Act of 1974, more or less saying, let's move to a capitation model. It seems like it's back to the future. What was missing was health IT and actually some sort of cost accounting to make performance metrics come in. Maybe now with the stimulus bill that will happen, but that's still a long time coming. The concern is that that design tried to emphasize prevention financially by having extremely low copays. The unintended consequences of that was that when pharmaceuticals went from basically non-trivial expenses to suddenly being covered by generous health insurance plans, those $5 or $10 copays got translated beyond just an office visit practice with a gatekeeper that was mandatory to everyone. That's what's driven up our costs. We're the enemy of ourselves here. So the way to fix it, if you want to fix it and have it budget be neutral, individual mandate, catastrophic plans, let the rest buy up by state preference, however you want to do it. That's budget neutral, and it would actually preserve the most important thing that I think Americans want, and I think it's in your surveys.
Well, let me respond to that because I only have actually 25 seconds left. Again, coming from the state of Texas, where we have individual state options, we have 900,000 children in Texas right now who are qualified for S-CHIP or Medicaid who are not on it because the state won't pass the match. The one thing that I asked the chair to have a national plan and don't come up with something that will say the states will make this option because we know what will happen in certain states. And again, I was a legislator for 20 years in Texas, and so I bring that as experience to you. So I know I'm out of time, Mr. Chairman. Thank you.
Thank you. Gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. I wanted to just comment. I'm going to sound a little bit like a broken record on this because my fellow committee members have heard me talk about the public option that we have available in Wisconsin in our Medicare Part D program. And I don't know if any of the witnesses today have had a chance to study that, but to me, it's ample evidence that a public option can be available and can compete favorably. Let me just quickly comment on it. For perhaps a series of coincidences, we had a pharmacy waiver before the Medicare Part D program was implemented. We had a program available to seniors in Wisconsin called Senior Care. Our congressional delegation fought on a bipartisan basis to keep that program when Medicare Part D was implemented and make it a choice available to seniors and other eligible folks in Wisconsin. And it has operated at about a third of the cost per enrollee compared with the private sector options. But for those who think that having such a public option would drive away the private sector competition, I can also tell you that Wisconsin has among the most vibrant array of private options for its citizens. I think I've heard more than any other state in the union. So I just want to draw that to people's attention, and perhaps when grilled about is there an example that you can point to anywhere in the country of an exchange that's been set up with a public option competing with private options, you can study this, and I think it's a great example. I want to move from that to a related issue of state innovation as we move forward with this. Mr. Kirsch, you are committed to a strong and robust public health insurance option, and I'm interested in your perspective on the role of states. Do you think that the ability of states to play a role in running these exchanges will enhance a national exchange, and do you think that this ability will empower them to build upon the reforms that we pass at the national level?
Well, the legislation, as I read it, says states or groups of states can set up exchanges. And, you know, we think that that's an important option. Doesn't have to be just an individual state. I mean, you want these exchanges to, every time you create an exchange, you have to set up another entity. And so, you know, if groups of states can do it, maybe more efficient than having individual states do it. And, you know, if you have a national public health insurance option, such as proposed, then it's going to deal with each exchange. And so it becomes, you know, one more way of less administrative hassle if it's dealing with fewer exchanges. So it's fine to say states can do this, but we think groups of states doing it, looking at more efficient ways to set up exchanges, manage them, makes sense too. There's no reason just because we have 50 states in the country that we have to have 50 separate exchanges.
I don't know if Dr. Parenti or Mr. Neese have any comments on the state role in this.
I think states are a tremendous place for innovation. Actually, what I would welcome to see is how an exchange would go forward. It actually would be something to repeal McCarran-Ferguson and allow states to compete across across state lines, because that would allow the innovations of those private players in Wisconsin that have demonstrated such innovation to actually compete in Santa Fe. I think that would be a nice solution.
Mr. Neese?
Congresswoman, I think this is an excellent question to ask, and it reminds me of a conversation I just had with my boss, Dr. Henry Simmons, a few days ago. We're talking, obviously, about having a comprehensive, system-wide, national health care plan. However, this is only the first half of what we have to do. Once this is enacted this year, then we're going to have to implement it, oversee it, and enforce it. And I think the states are going to play an incredibly important role in that, in be partnering with the federal government. I think it does reinforce what this committee's role is going to be in overseeing whatever does get done at that level, as well as organizations like ourselves. The implementation and enforcement of this law, which will hopefully be done in conjunction with the states, is a question that should be addressed now and forevermore.
Thank you.
Thank you. Gentleman from Kentucky, Mr. Whitfield.
Thank you, Mr. Chairman. Dr. Parenti, you mentioned the staggering national debt, and we're on the verge of making a multi-trillion-dollar decision relating to health care. In your mind, are there more cost-effective alternatives to expanding health insurance coverage than the Kennedy bill or the bill before us today?
Like as I said in the testimony, it's hard to sort of have a silver bullet for this at all. I think if you have a mandate on some very basic coverage with some provisions for prevention, that will lower the price tag considerably, perhaps by half. It still may not make it free. You're going to need to find some way to have this be paid for. But what it does is it actually sort of says to the American people, you have a right so that if something happens and you face a catastrophic illness, you will be covered, and you will have choice of physician, and that's what we will guarantee. But to actually go beyond that and to put it into you have a right to a public option plan, which is based on sort of an FEHBP model of a Blue Cross Blue Shield plan that's been morphing for the last 60 years, adds a little too much extra costs, approximately probably 70% extra costs than you need to have, and probably reinforces the same behaviors you have in the inefficient system we have today.
Well, you know, of course, all of us are concerned about cost, and that is particularly important today with the economy being what it is and the amount of money that we are spending. But in addition to that, of course, the American people want a quality health care system that they all have access to. They want health insurance that they can afford. And we want models that can be adopted that we do not have this spiraling cost in health care. And I've been reading recently, and I know he's testified over on the Senate side quite a bit, the CEO of Safeway. And I know that when the Medicare program started in 1965, CBO estimated that by 1990 the cost would be somewhere around $9 billion. As it turned out, in 1990, the cost was around $100 billion or so. The thing that I like about the Safeway model, it appears from the evidence that the CEO is providing that they've actually been able to control health care, the cost. But more important, they've given their employees the right to make decisions on who they want to see, and they also have developed a system of transparency so that employees can shop around and determine the cost that various providers charge, and there's a real disparity in that. So I would like to get your comments, those of you who are familiar with the Safeway program, and Mr. Neese, I know you would like to make a comment on it, so go ahead.
I do want to salute Stephen Byrd, I believe, is the CEO of Safeway, and all those who make voluntary efforts with respect to well-being and prevention. I don't think there are any independent studies that corroborate what Mr. Byrd has put before the committees of the House and the Senate. And you're talking about cost. I do think that much of what's in the bill, whether it's the Kennedy bill or this bill or things that the President have brought up, they're good, long-range cost savings measures. I don't think anyone really has yet addressed the short term. And I think we're going to need some short-term regulatory constraints on the increase in the expenses system-wide. As Congresswoman Schakowsky was saying, it's everyone's responsibility, but we need some short-term cost control in the bills that come out of the House and Senate, not just the long-term cost-saving measures. And I would hope that would be something that this committee and others would address.
Yeah.
I think it's good about what Steve Byrd's done at Safeway and people have done at Pitney Bowes and a lot of other companies in the country is they've actually looked at ways to control costs. And as you said, the key has been to not have financial barriers, to preventive care, to get people in the system early. And one of the reasons we want a hybrid system is to encourage that kind of innovation. And have encouraged it more in Medicare. If you look at the Senator Baucus's options paper, it's all these things that Medicare has done to be innovative. So let's have the private sector innovate. Let's have the public sector innovate. Let's look for better delivery systems. That's what we've got to do if we're going to move towards a solution that makes this affordable for everybody.
Right. Just a quick comment. I studied consumer-driven health plans, and actually there's a report ahead that was published by HHS last year that looks at a design very similar to Safeway and found that it actually saved costs, at least bent down the curve, and prevention wasn't touched. That's why I'm advocating that as a model, because I think that could be a very cost-effective solution if the financial incentives were structured that way.
Thank you. I guess my time has expired.
Thanks. Gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman, and thank you all for your advocacy efforts. Briefly, could you all in 20 seconds take a turn and characterize CEO profits of HMOs and HMO or CEO salaries, HMO CEO salaries and HMO profits over the past 10 years?
I would have to give you my personal anecdotal response to that it seems excessively high over the last 10 years. There seem to have been numerous press stories that underscore the extravagancy of some of those salaries and some of those profits.
I think we're looking at average CEO salaries of $12 million for the top 10 insurance companies in 2007, average profits of about $12 billion, $13 billion.
Did you say billion?
Billion for the profits, top 10 CEO salaries of $12 million. And if I believe there was a 400% increase in profitability from around 2000, 2007. I'm doing this from sort of my visual memory, but gives you a scale of the kind of increase in profits we've seen in the industry over the last. And I want to conclude with a quote from Angela Braley, the CEO of WellPoint, when talking to financial analysts about what kind of decisions they're making, says, we will not, this is a whole sentence, we will not sacrifice membership for profitability. In other words, we're not insuring more people if we're going to lose money on them because they cost us too much.
They've been going up. We all know that. The question is whether or not they're returning value. I spent 2 or 3 years working at a nonprofit Blue Cross Blue Shield plan. I liked the people. I liked the management. I was sort of disturbed by how inefficient everything could be. That's what drove me to become an academic, I suppose. And no comments there. But what I found in terms of some of the good plans that are publicly traded is they introduced innovations that I was dying to see done in those nonprofit Blue Cross Blue Shields. And if there was anything I think that is a virtue to this public option plan is to put some competition into those plans for better business practices. But keep in mind, those better business practices I see coming mostly out of the for-profit plans that are being demonized. So I'm of mixed mind when talking about what the return on investment of those salaries tend to be.
Well, let's just... I think we can all agree. The American people are concerned, to put it mildly. I would say that they are angry. In my home state of Florida, there is a recent example with the largest managed care provider, private HMO, that has just, that's offices were raided some time ago by the FBI, charged by the Justice Department, and just settled a case because Florida had embarked on a pilot project to privatize Medicaid. So this private HMO came in and won the bid, and it turned out that they were paid money to provide health care services for children under Medicaid and under the state children's health insurance company, and rather than provide the medical services, they pocketed the money and have just settled the case for $80 million that they're going to pay back to the state of Florida. Meanwhile, the CEO was receiving multi-million-dollar salaries. They were posting the highest profit margins in the history of managed care in our state. So when we talk about cost, isn't there enough cost? Isn't there enough money in the healthcare system now? In fact, the CEO of a Florida HMO paid a visit last week, and that's exactly what he said to me. There is enough money in the system. If you adopt the public option and a comprehensive health care reform bill, we can get this done. In contrast to all that, what's happening to the average American family? Health care costs are driving Americans into financial ruin. A recent Harvard University study said that 62% of bankruptcy cases now are caused or influenced by medical bills. 62%. In 2001, it was 50%, and in 1981, it was 8%. And now, with the rising numbers of uninsured, they're often completely hammered because they have to pay the entire bill, whereas if you actually have health insurance, you benefit from the negotiated lower prices. Many people in this day and age really have nothing left because they took out a mortgage on their home. Now their home is worth thousands and thousands of dollars less. Isn't the real crowd-out issue the fact that Americans do not have access to affordable health care? Health care costs have skyrocketed and their paychecks haven't kept up. Isn't that the real crowd-out issue we're going to tackle in this health care reform?
Absolutely.
Absolutely.
I know I only have a second here. The reason why costs go up is that we like medical care and it works really well. And societally, that is a decision we are taking. Individually, everyone has their hardship concerns, and I do not belittle at all what you're saying. But understand why this is occurring. Healthcare is a good, and we all want it. And we're not willing necessarily collectively or found the right mechanism to distribute that desire to meet our economic challenges.
I would just say, if you look around the world, you see there's higher utilization in a lot of countries, and they spend a lot less and get good quality. So I would disagree with Dr. Parenti.
And let me make one personal comment back to that. I worked for the British National Health Service. It was my first job because I believed in single payer when I was 21 years old. When I worked for the British National Health Service, I was in southwest London in a teaching hospital. Here's how they save money, because they still do it the same way. Would you like to guess here, anyone, how many long-term beds, skilled nursing beds they had available for 250,000 people in that space? Anyone? How about 31? That's how you save money. And how they did it, that's why UK has the most advanced hospice program in the world. Because in order to save those resources with a soft velvet touch, you basically were to say to someone who was 80, you have CHF, I'm sorry, this is the end of the road, let's make you comfortable. Here we don't do that as much.
Congresswoman, you're really getting to the heart of the matter here as to why we have the kind of polling that we have. People are starting to find out about these outrages. And we do have some of the finest, if not the finest, health care in the world. But as Mrs. Christensen said, if you can afford it, but there are tremendous disparities. And I said a little while ago, 400,000 preventable deaths per year in our system. 400,000, costing $700, $800 billion a year. These are all costs that could be addressed by systemic, system-wide care. This is a scandal that this is happening, absolutely a scandal. And you were talking about the cost for individuals and the bankruptcies, 4 times as much for health care costs as the increase in wages. When people find out about this, as good as the polls are now, they're going to be even better. There's going to be a popular uprising on behalf of this kind of bill and for comprehensive health care reform this year. It's absolutely necessary.
I let them go because I didn't want them not to have the opportunity to answer your question, but we've got to move on. Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman. Mr. Kirsch, I want to thank you for being here. I want to thank you all for being here. And Mr. Nace, thank you for the leadership of your very diverse coalition. We appreciate it. But Mr. Kirsch, the coalition's 5 basic principles for health care reform: coverage for all, cost containment, improved quality and safety, simplified administration, and equitable financing. That's how you, or am I, is it Mr. Neese? I'm sorry, Mr. Neese. I apologize.
That's all right.
I bet you agree with those principles.
Sure.
Okay. Mr. Neese, those are the broad principles that your coalition is fighting for in a health care reform. Is that correct?
Those 5 principles buttressed by many, many specifications that are part of our pamphlet. I bring this everywhere, just like Senator Robert Byrd brings his copy of the Constitution. I bring this blueprint for reform, which has specifications that 80 organizations spent 18 months putting together to implement those 5 principles.
And I appreciate that, and I appreciate that commitment, much the way I appreciate the commitment to the Constitution. Dr. Parenti, do you agree with those 5 basic principles for health care reform?
Yes.
Okay. And I just have a question, Dr. Parenti, about, I apologize that I didn't get to hear your testimony, but I did get to read it. And so based on that, you discuss at some length the parts of health care reform that can create costs without any regard for the many cost savers that will be included. So in particular, I'm interested in your score of the public health plan option. You don't seem to consider that with a public health plan comes increased competition. You sort of almost scoff at that in your testimony, that will increase access and drive down premiums for beneficiaries. Why do you choose to disregard that?
Because there's not a study to show that would work.
Okay, so you're just, until somebody shows you a study, and I heard Ms. Baldwin talking about what is true in her state. Are you saying that there's no demonstrable evidence based on what is happening there to support this kind of conclusion?
Not on a national scale. I am from the upper Midwest as well. We in the upper Midwest, as was in the New Yorker article, just do things differently. We're more cooperative, maybe because it's cold. But to generalize this out to the nation is not easy to do. I mean, just take the examples from Florida. I guarantee you Wisconsin, Iowa, and Minnesota are really low on fraud. Florida, on the other hand, is the capital for the world. To find a one-size-fits-all solution is going to be difficult. That's why I propose if you are going to be doing something like an exchange, let insurance companies buy in each other's markets or compete in each other's markets and not be constricted to the same state-specific things that McCarran-Ferguson does today.
You know, a couple of things. You will concede then, though, that there is some on a statewide basis evidence to support that it could drive, that a public plan can drive down costs and increase competition.
No, not at a national scale.
I know, I said at a state level.
There's evidence of state innovation that's successful.
Okay. Mr. Kirsch, would you like to comment?
Well, Medicare has about less than 5% annual inflation. Private insurance is about a 7.5% medical inflation. Commonwealth Fund thinks the premiums, if we use Medicare rates, you guys are talking about Medicare plus 5% would have 20, 30% savings. So there are studies. Urban Institute says it'll save money. Jacob Packer at Berkeley thinks it'll save money. So there are a bunch of studies that say it'll actually save significant money, and we've seen that Medicare has lower inflation than private insurance. So I would beg to differ.
Okay, thank you. Dr. Parente, can you tell me, do you think that the majority of the millions of uninsured Americans, do you think that they're just simply waiting for the right plan to come along?
No, I think that there is a real problem. Most people would refer to this as a market failure to have this level of folks be uninsured. I think the question people have to ask is when people hear that 45 or probably now 50 million number by the time this year shakes out, it's the question I think people think about is that the number of people that started the year uninsured and ended the year uninsured and found nothing in between? Because that number is quite different. That number is a fraction of 50 million.
With all due respect, I think people, when they hear that number, think that is totally unacceptable in a country as great as this, that we would have millions of people uninsured with access to care when they need it.
No,
I'm going to move on. I just have
I would agree. What I'm saying is focus on the folks that start and finish the year uninsured. That's a priority.
Do you think that the American people who have insurance through the private insurance industry are very pleased with their care?
I've seen surveys that suggest that they're not, but it's a heterogeneous mix, and they are upset for different reasons.
Do you think that it's appropriate that the pre-existing condition exclusions that exist in the private market should continue?
It all depends upon whether those pre-existing conditions actually really get premium to a point where insurance is unaffordable, which actually in several states it has done.
Okay, I know that my time is up. Thank you.
Thank you. The gentlewoman from California, Ms. Matsui.
Thank you, Mr. Chairman. I'd like to focus in on one area, although I like to ask a lot of questions, but this is one area I'm really focused in on, and that's prevention as overall part of the health care reform. And we can't forget it because we understand that we need to prevent people from getting chronic diseases like heart disease, diabetes, and asthma. And unless we do, the costs of our health care system will just go up, no matter how well an insurance exchange is structured. More than 75% of the health spending in this country today is attributable to chronic illness, but only about 3% of our health care spending is for preventive services and disease promotion. Mr. Kirsch, your organization platform states that health care reform will emphasize quality care, including coverage for prevention and primary care, and good management of chronic conditions. And as you know, our draft bill requires insurance companies to cover preventive services and waives all co-payments for these services. Is your organization's vision for preventive care fulfilled in this legislative draft before us today?
Well, yes. In terms of the benefit package, absolutely. because what you've done is, as you said, you've made prevention a standard part of the benefit package, and eventually employer-based coverage as well as the exchange, and you've done it without financial barriers to care. And you've also made a significant investment in the legislation into increasing the number of primary care providers, because we're going to need that to be sure those preventive cares are delivered.
But do you think the bill could be strengthened to place an even greater emphasis on preventive care?
Well, the benefit package in terms of prevention care is good. Now, some of the details of the benefit package are going to be left under your bill to a board to set that. The question of how much is put in law now versus not. But the point is, you've said prevention, you've said financial barriers, you've made the investment in primary care infrastructure. So we think these are really, really good.
Okay. Given that the draft bill requires a certain level of coverage for preventive care services already, do you see any role for the public option in driving private insurance toward a model that focuses more on services that will help people avoid getting sick in the first place?
Well, we'd hope so. I mean, I had an interesting conversation years ago with the CEO of an insurance company who said, it doesn't pay for us to invest in prevention because we're only going to have these folks for a year or two, so any savings won't accrue to our benefit. That's the kind of calculation you make if you run an insurance company. Or you just do your marketing to people who don't need a lot of health care in the first place. A public option whose mandate is the public good, who's looking at the long term, will have a different set of incentives to look at how do we promote the public health, how do we keep people in, how do we avoid them getting sick, how do we have good chronic care management, and innovate in that. And it's very important that one of the goals you've specifically laid out in this legislation for the public option is innovating delivery system options that do that. And so not being simply, Medicare's done some of that, Medicare needs to do better, but the fact that you've made that a specific mandate for the public option is incredibly important.
So you think this is a real opportunity here in the public option aspect of it?
The public option actually specifically is charged by legislation with doing that kind of innovation delivery system to focus on better chronic care management, to do the kind of things you're asking about.
Mr. Neese, you...
Just want to add to that, there are some excellent provisions in the bill, and I think there's more and more discussion with respect to best practices and looking at Intermountain and Cleveland and Mayo and other places. But I think it's very important to make sure that your deliberations and your eventual decisions and how it's implemented is evidence-based. And I think that is so essential for making this all work.
I believe that too, and I think that there is evidence available.
Yes.
Is trying to get the evidence in a manner which we could actually compare. And prevention and wellness for many people seem to be more something that is a fluffier side. But for me, I would rather not get sick. And I think if we don't get sick, we'll probably lower the health care costs anyway. But I was also considering, too, what Mr. Neese, you did a lot of work on health care costs and how they hurt small businesses. And can we use the same model here that Safeway has used as far as what they've done as far as prevention and wellness, as far as having small businesses do the same things, too?
I had an opportunity to respond to another member regarding Stephen Byrd and Safeway and saluted him for his innovations and his well-being and prevention efforts. I also did hasten to add that there hadn't been any independent study to corroborate some of the claims that have been made. But certainly we want to welcome efforts by the private sector, by everyone, to try to keep people well, to prevent things from happening. That's an important part of the equation.
Right. I think I'm running out of time, but just quickly.
Let me just quickly, though, I think what the key and one of the reasons to have something like a strong public option is how are we going to take, it's great that Safeway or Pitney Bowes or Textron or IBM can do it. How are we going to translate that into small businesses? If we have public option that drives those things and then small business and the exchange can benefit for their employees, we can make it more than just the innovators in the private sector.
That's great. Thank you.
Thank you. Gentleman from Utah, Mr. Matheson. Gentleman from Massachusetts, Mr. Markey.
Thank you, Mr. Chairman, very much. This is an historic time, and we're very proud in Massachusetts that we adopted a new law that puts us in the same role as revolutionaries that our state has historically played in many other areas, except we're not any longer talking about Minute Men, but Minute Clinics up in Massachusetts, and not red coats, but the white coats of doctors in terms of this revolution that we're trying to create. What I would ask is if we could get your opinion as to this Massachusetts plan and what lessons you draw from it and what you would try to emulate or avoid in moving forward. We have moved now to 97.4% of our citizens with coverage, which is something that obviously we had as our goal. It's only been in place for a couple of years, but it obviously has been successful to that extent. But Mr. Nees, could we begin with you, and welcome back to this committee for the many times you've been here, and whatever observations you have, I would very much appreciate.
Mr. Chairman, it's an honor and a pleasure to be back here. And as you know, as a product of Massachusetts, as the former chief counsel to Republican Senator Edward W. Brooke, I am very proud of what Massachusetts has done. Senator Kennedy, yourself, the legislature, Mitt Romney, and others, especially with respect to, I believe, including about 95% so far of the population of Massachusetts. Having said that, I know Massachusetts made a political decision several years ago that it was not going to address the cost management issues at that time. So we have my very good friend, Governor Deval Patrick, going to the legislature right now and going around the state to make sure there's additional legislation that would address the skyrocketing costs and increase in costs that affects Massachusetts and every other state in the union and is such a national emergency. So there are wonderful lessons to be learned from Massachusetts. There are also lessons that you expected. That it was not a sustainable plan unless the money was going to be raised or the cost containment issues were going to be addressed. I think Massachusetts is starting to do that, and I believe with a national plan that addresses health care reform in a system-wide way and works in partnership with Massachusetts, the Paul Revere work that's been done will be completed over the next few years, the next number of years.
Thank you, Mr. Nees. Mr. Kirsch.
So I have a daughter who's a nurse at Children's Hospital in Boston.
Beautiful.
But probably in terms of your question, more importantly, I have a daughter who just moved to Boston, to Somerville, has taken not a very well-paying job between college and graduate school, but has good health insurance because of what you've done.
Mm-hmm.
And when she was between jobs, we had to pay more than $300 for a medication she's on for a chronic condition.
Mm-hmm.
It was a lot of money for us to pay. Fortunately, we were able to do that. What would have happened if she weren't able to have that, now be able to get that coverage through the plan? The plan has been successful by expanding coverage to low-income and moderate-income people in Massachusetts. It's extraordinarily important. Where are the things that we think can be improved? One is, unfortunately, and this is a fiscal problem because the state's just doing it, the subsidies don't go more than 300% of poverty level, which means there are a set of people who've been exempt from the program because it's not affordable. What's good about your legislation is it goes up to 400% of poverty level. It also allows you to look at regional differences in cost and ask the Secretary to do this, which is very important. Second of all, it doesn't have a public option in Massachusetts, and by injecting that kind of way of controlling costs, that's an important factor. Third, you don't really have employer responsibility because of the ERISA challenges and also because Governor Romney wasn't crazy about it. The employer responsibility is very important in terms of providing a lot more revenues. You've been able to get away with it in Massachusetts because you're one of the highest employee-sponsored insurance penetrations in the country. You can't do that other places. So a lot of good things in Massachusetts model you've shown, but some things that we think can strengthen it. And as Mr. Neese said, you're all starting to deal with the cost control issues which are being built into the federal reforms.
Okay, thank you, sir. Dr. Parente.
I think you should be applauded for doing it. I think it's a landmark initiative. The costs are the big issue, as are being discussed and have been previously mentioned. I think also could be longer-term issues in terms of competition. One thing that was learned that actually some of our work showed previously was that some of the higher deductible plans or the low-option PPOs would be the magic price point to get many people to get the right incentives to come in. And we just have to be sure that if this happens, what we're discussing here, that those options are on the table as well. One thing I'll make a very brief comment was that you really need to have as many private insurers come in to compete as you can, and I remember that was an initial concern, but it looks like it's being addressed.
Thank you, Dr. Parente, but there are a lot of things in common, Mr. Chairman. It's You know, it includes expanding Medicaid, creating a connector to help patients select a plan, and helping to subsidize the low-income citizens so that they can have access to health care. So I think the general principles are very similar, and we can learn, actually, from what went well and what needs to be reformed in the future, and I thank you for your leadership.
Absolutely.
Thank you. And I think we're done with Mr. Dingell. Chairman Dingell?
Sure.
Mr. Dingell? Oh, there we go.
Thank you, Mr. Chairman. Your study of the costs was just limited to the Kennedy bill. Is that correct?
There was also done one of Coburn Ryan and also one on the Senate Finance Committee as well.
I see. You've not done one on the bill that's rather on the draft that's
No, as I mentioned earlier, I hope to have estimates on that done by tomorrow morning at 8 a.m.
Okay. Now, I'm curious. You mentioned the English health system. Is there any significant similarity between the English health system, of which you appear to be critical, and the discussion draft that's before the committee?
Actually, I'm not critical of the English system. I'm just bringing it up as a comment. I think both systems grew out of the, if you will, the socioeconomic history of each country.
Well, but there's no similarity between the two, is there?
Well, there will be increasing similarities if we have to ration care.
Why do you make that statement?
Because the only way you can actually hold the cost curve down effectively with Medicare is effectively to put limitations.
This is your assumption, is that correct?
It is an assumption.
And as in all other studies, the study is only as good as the assumption, isn't that right? Garbage in, garbage out.
Not necessarily. I mean, if it's garbage in, garbage out, then all the Commonwealth and stuff has to be thrown out too,
Now,
Congressman Dingell.
You have this is not a single payer system that we're talking about here, is it? The European system is a single payer system to which you're referring, isn't that right?
The European system is made up of many countries that constitute
Let's
Europe.
talk about the British, because that was...
They're not all single-payer systems. The UK actually has moved toward...
The British system is a single-payer system, is it not?
It is a single employer system, yes.
Now, your assumption that there will be rationing, there's rationing right now, isn't there?
Yes, there is.
We have 47 million Americans who don't have any health care. And during the course of a year, we have as many as 86 million who have no health care. Obviously, those people without health care are being rationed, are they not?
Yes, they are.
Okay. I guess that's all the questions I wanted to ask. Thank you, Mr. Chairman. Thank you, gentlemen.
Thank you, Chairman Dingell. And I think we're done with questions, so I want to thank you all. It was very helpful. Appreciate it. And, you know, as we move along, we're going to certainly keep your ideas in mind. Thank you.
Thanks, Mr. Chairman.
And I'd ask the next panel to come forward. And let me remind members that we are not taking a lunch break. And the reason for that is because I think as the day goes on, we'll get more members of the full committee who, as I mentioned, can participate. So if you want to take lunch, maybe go while another member questions.
Richard, well done. Thanks a lot. I appreciate it.